So, good evening and happy Doctors' Day to all. And before we get started with this webinar, I must thank all of you because this audience that we're getting from you is quite encouraging. We at Grid have been experimenting with the type of content we create, and much of our approach has been based on the principles of design thinking. We design courses, we design projects, we design initiatives which are human-centered, client-centered. And a part of it is about creative collaborations, inclusive collaborations. And your participation endorses that we are creating content which has an audience, and this audience has tastes that is similar to ours. This is really encouraging. Now, we have some good news to share. We had kept an internal targets of achieving 500 members on Telegram and 1,000 members on LinkedIn by 30th June. Now today is 1st of July and we have 524 members on Telegram and 992 members on LinkedIn. So that's almost, we are hitting our targets there. And now we have also ramified a bit more. So we have started physical workshops. So Grid workshops, both physical and virtual workshops have started. And we have been able to sponsor a couple of events. Now we are allocating a very small budget. Now our capacity is limited, but we are allocating a budget for sponsoring different events. So in case you want to do anything at your own local place, anything disruptive, anything innovative, please let us know. We'll see if we could fund some of it. Small budget, maybe 10,000, 20,000, but then whatever we could do. The other thing is, suppose you have a skill and you want to disseminate. You can design some kind of training, because India is a huge country. All of us have different skill sets. You have something unique. Let us know. Maybe we can organize some webinar. You can come on this platform and share your skills with others. Now with this, I'm really excited because today we have a project that we shall be talking about later on. But before that, we have a very experienced NCD expert. She will be talking to us very soon. To take the proceedings forward, I have my colleague, Dr. Shaili Vyas. She is a professor at in the Department of Community Medicine at Himalayan Institute of Medical Sciences. She is the co-PI of this project that we shall be talking later on, which was funded by World NCD Federation. We have a representative, Dr. Nangia, joining from World NCD Federation then. So over to Shaili to take over the presentations.
Thank you, Dr. Rajeshman. Today we have with us an eminent speaker, Dr. Barrett Allen. She's a professor at AIIMS New Delhi. She's an alumni of AIIMS New Delhi itself. Her area of work includes NCDs, cancer prevention and control, medical education, primary healthcare, urban health, health system, and programs. She's involved with numerous research projects on NCD funded by WHO and ICMR. She's a national trainer for NPCDCS. She has also developed a training package for program managers in NCD programs in various states in India, which is supported by WHO. She has also developed a training package for WHO PEN implementation for WHO headquarters Geneva and trained health workers in Africa on WHO PEN. She has also developed patient education material and job aids for NCDs under WHO CRO in the year 2018 and 19. Also, she has developed various resource material for management of diabetes for WHO headquarters. Last but not the least, she's a part of AIIMS technical support unit for Minerva. The virtual platform is all yours, ma'am.
Thank you. And I'm really glad to be here today in this forum and very encouraging to see so many young faces. I wish it was all a physical meeting, but and nevertheless, it's very, I'm really happy to see the response by all of you. And I believe that most of you are PG students, right? So before I start, I just want to ask you to, I hope all of you have downloaded the app. In case you have not, then kindly do so in the process of while I am doing my presentation. So without delaying any further, I'll go straight away to the actual session, which has been allotted to me. And that is an orientation of the WHO package of essential NCD interventions for primary healthcare settings. So I hope my screen is visible, Dr. Shaili.
Yes, ma'am, it's visible.
Okay. So in this era, which I mean, all of us know that NCDs are an upcoming health problem, and it is actually overwhelming our health systems. And more and more, we are looking at the strengthening of the primary healthcare system in order to tackle or to manage NCDs, because NCDs cannot be managed at the secondary or the tertiary systems alone. Otherwise, our systems will all collapse. And most of these conditions, the NCDs, are actually manageable at the primary care settings. So in order to strengthen the primary healthcare systems, there are certain things that are needed. uh, our healthcare systems have to be equipped with certain minimum criteria, facilities in order to provide NCD services. So basically, I just wanted to tell you that WHO package of NCD, or what we call PEN, is nothing like, it's not really something which is very complicated. It's basically a set of cost-effective interventions. Okay, it brings together all the updated guidelines, protocols to empower primary care physicians. And in some countries where there are no physicians, we actually train health workers to manage NCDs in the primary care settings. So this is, it's nothing like, a special kind of a package, but it's actually the guidance and tools and certain minimum criteria that must be met for primary care settings to manage NCDs. So these are the components of WHO PEN. You can see that it includes all these common NCDs, the management of cardiovascular diseases, diabetes, CRD, cancers, early diagnosis of cancer, not the advanced stages, but the early diagnosis of cancer, which is mainly focusing on cervical and breast cancer. Healthy lifestyle counseling, as we know, is the mainstay of NCD prevention, and it always will be. Self-care and palliative care have been added as a recent components of PEN, because no matter whatever be the case, self-care is very important, and palliative care in order to manage the end stage diseases. So now the PEN has gone on a long journey. The components of NCD management started actually in 2002, where individual components of these of NCDs were guided, or guidelines were provided in different through different documents, through different meetings, through different guidelines, and ultimately all of them have been brought together in 2020 under the name of WHO PEN, which is the latest update, which was done in 2019. And I'm fortunate to actually also have been very much a part of this update. So this is the entire journey, which is now, that's why I wanted to share all of this with you, so that all of you will also get the updated knowledge about the NCD management in primary care. But before that, I'll also like to introduce you a little bit about this HEARTS. I know many of the students, or many people, are confused. What is HEARTS? What is PEN? But actually, there's no need to be confused. This is actually the HEARTS is the cardiovascular component of PEN. Why did we need to develop the separate HEARTS modules or HEARTS package? See, in most of the countries of the world, you must understand that WHO works across regions, across countries. And in many countries, for example, the West, they really are out of the, I mean, their focus is more on cardiovascular diseases and not really on CRD. So for this reason, the HEARTS technical package was introduced, which was mostly included cardiovascular disease management, diabetes, that means hypertension and diabetes. But as I told you, in the evolution of PEN, the HEARTS has been also included. It has now been embedded under the PEN. So we don't say HEARTS anymore, but we say that the PEN overall provides guidance for management of cardiovascular diseases, and that cardiovascular disease component has come from the HEARTS technical package. But a little bit, I'll just tell you what is HEARTS. See, HEARTS stands for H is healthy lifestyle counseling, evidence-based protocols, access to essential medicines and technology, T for team-based care, and S for systems of monitoring. So these are the modules that have been provided, and I'll share with you the link. All of you, especially as postgraduate students, I urge, I would suggest that you read these modules. They are very crisp, very practical modules. which are very useful, and I'm sure that all of you will find it interesting. See, the first one is the healthy lifestyle counseling that includes all the healthy lifestyle counseling methods and all that we all are familiar with. There's really nothing, it's nothing different. The second one, which is the evidence-based protocol, I think all of you must look at this because it has the guidelines for hypertension and diabetes. Now, a little bit more, I just want to spend here because yeah, all of you should know what is where. So the evidence-based protocols here contains 7 protocols for hypertension and diabetes protocols. Why 7 hypertension protocols? See, as you know that hypertension has, there are various ways to manage hypertension. In some conditions, you know, you would like to start with diuretics, or some physicians prefer to start with calcium channel blockers or ACE inhibitors. So all these conditions have been taken care of, and they have provided 7 protocols. So each one has been validated, and then they are evidence-based protocols which have been developed along with experts around the world. And so it gives us a variety, you know, or you can choose. It depends on the availability of drugs in your place, in your region. Then the third one is access to essential medicines and technology, which is actually, gives you a step-by-step guidance as how to arrange or how to provide access to medicines and technology. It gives you a practical explanation as to how to estimate the requirement of drugs in a particular facility. Then the R is risk-based CVD management module, which is the CVD Risk Assessment, which we will talk about later. And then team-based care, the T module. So all of us must understand, and I'm sure we appreciate that in management of NCDs, it's not only the doctors alone who are important, it is a team of doctors, nurses, health workers, counselors. So the team-based care module actually looks into the team-based care development of a team-based care model, and how are you going, what and who is going to do their roles and responsibilities in primary care prevention and management of NCDs. And last but not the least, the systems for monitoring. I think this is the weakest part of the NCD management chain, wherein I don't know how many of you have read or have heard about cohort monitoring. So this is actually the beginning of the cohort monitoring concept. And in this module, it has been given very nicely about how to do the cohort monitoring. So all of you can read about it. And if the organizers permit, we may also have a separate session only on the cohort monitoring and how to monitor the NCD management using the cohort monitoring concept. So then there is a module on diabetes as well. And so that is about the hearts. I just wanted to take a little bit more time in this so that you all understand about the hearts modules. So now back to that. So now all of these things have been subsumed into the WHO pen. Now this is a manual. I've sent the link for this manual. It is available freely on the WHO website, but it is also now converted to an app. All the contents of the module have been are present in the app. So all of you, I hope by now you have downloaded this app. It is a very useful. It's a one-stop shop for management for all the information, in fact, for NCDs at primary care level in your fingertips. So you can, those of you who have downloaded, you'll see that these are the features. And let me start with the roadmap. If you open the app, you'll find the roadmap. Now, all of these documents are the ones which I have showed you in the roadmap from 2002 to 2020. And you can click on these documents and download them or read them in your mobile whenever, and I mean, they are downloadable. That is what I wanted to say. So you can refer to them anytime and you can download them from your mobile. And then we come to the NCD interventions. Here, each cell is pertains to one condition. Say cardiovascular diseases, if we look at the cardiovascular diseases component, if you click on it, you'll find these 3 things: the cardiovascular risk assessment management. Here, this is the CVD calculator. Then you have guidelines on hypertension and the heart's technical package. So this is when you click on the CVD risk assessment icon, you'll see this, and it exactly gives you what to do when to do risk assessment. We will be doing that subsequently if time permits today. And you'll have the CVD risk calculator. One is lab-based and non-lab-based. And this is how it looks. You will have, you can calculate the risk for all of the 184 countries in all over. But for us, we are concerned with India, so we are not really bothered about others. But then after that, we also have the information as to what to do when, when the risk is say like 5% or 10%. So after you calculate the risk, you also have a management guidelines according to the risk level. And then you can look at the non-lab based risks where you'll need the BMI to be calculated along with that. So we'll go through the details of that when we go to the exercise. Then the hypertension module will give you all the details about, in a very simplified manner and easy to access, what is the hypertension guidelines, the treatment goals. Then you have diabetes treatment goals and guidelines. Then CRD also provides all the guidelines for asthma and COPD, all of them which can be done at the primary care level. Then your modules for healthy lifestyle and counseling. Now, and after that, it doesn't end there. And as I said, PEN is actually, it provides a lot of guidelines. So once, on one side, you have the knowledge, and other side, you have the service delivery model. You have your health centers or your the healthcare settings, but how do we do it? How do we translate it? So it provides you guidance by the enablers or the tools by which you can go about managing this. Setting up the NCD healthcare delivery system. So you have the first screen, which is stepwise approach. This is mainly, maybe it could be for us, it may not be that relevant, but for policymakers who have to start, NCD services, what are the conditions and how do they have to go about it? But I think for us right now, we can go to the second screen, the tools. Now, those of you who have the app, if you can open the health facility assessment tool, we will be doing an exercise based on this today. And then you also have a sample of a sample clinical record, which if you want, you can actually have a look at it and design a treatment card or clinical records for the patients in your own settings. Then, so Annex 4.1, the health facility assessment, this is what we will be using. Then we have the list of medicines and technologies, which are the minimum which are required for setting up NCD services in the primary care settings. Now, lastly, we have this capacity building section. So can you please mute yourself? So we, here in this pen also provides you certain resources where in the form of slides, for presentation. Many of the slides I have used now are also from this own app itself. And if you can go to that section on capacity building, you have slides for all of the conditions. And then you also have posters. If you have posters for all these conditions for PEN, which are covered under the WHO PEN. So now, lastly, where is this PEN being implemented? Who is doing this? It's not just an abstract kind of thing. Up till 2020, about more than 80 countries have actually adapted PEN and all its components. In fact, many of the countries in Southeast Asia, Africa, I've also been a part of the mission to Africa for, setting up these NCD services in many of these areas there in Bhutan and Nepal and all this. So it is very interesting to see that, especially in the African region, the in initial stages, as we all know, HIV is it's endemic there. I mean, it's a very big problem. So their health services were only geared towards HIV, but then they realized that, at the same time, hypertension is also becoming a very important problem. So they started looking at management of hypertension. So that's where, then they started moving towards developing NCD services. So similarly, Bhutan also was, and Bhutan is one very interesting country where they don't have doctors. I mean, they have, but very limited, and there's no medical college there. So all the doctors actually have to study outside. It's a very expensive affair to study medicine and for people of Bhutan. So there, what they have health workers, or they call health assistants, who actually manage the primary health centers. So they are the ones and so they actually follow the protocols step by step, and then they consult the physicians over the phone, when they have to manage certain complicated cases. So if you see in the map, you can, many of you may wonder, India, how is India? Is India implementing PEN? You may wonder, where is PEN in India? But let me tell you that PEN actually is a package of interventions, which is like, it's not a separate kind of a program. Now, if you think about it, all the components that I have mentioned are all under the NPCDCS program, isn't it? So when the NPCDCS program was planned, the WHO PEN was consulted, was referred, and it was, many of the components of the NPCDCS program have taken shape based on the WHO PEN. So that is, so it's not necessary that PEN, the program has to be called PEN. Though in many countries, like in Iran, it is called Iran PEN. In Mongolia, it is called MPEN. Maldives, many of these countries have used the word PEN, but in India, it is actually under the NPCDCS program itself. So it is not a strange program, it's nothing new, but it's basically how to strengthen the NCD care services in primary health, in primary care settings. So with that, I come to the end of my brief orientation. I don't want to take up too much of time because I want to move on to the next part, which is, I believe, would be more interesting for you. If Dr. Shelley can share the link for the health facility assessment.
I've shared the link in the chat box, ma'am.
Okay. So all of you have got this link. Now, what we are going to do now is all of you can just open that link and we will do a small exercise. So what I want to do today is let us look at our health facilities. Okay. Remember that this is not an assessment or an evaluation of any health facility, but what I want you to do is take a moment, think about any primary health center or urban health center. It could be your UHTC, RHTC, which you are working, or PHC, which you have seen and worked and you're familiar with. Think about the services which are provided there in any center, okay? And then you answer these questions one by one, and we'll see, whatever is the center that you're thinking about, do you think, let's see, how ready is it to cater to NCD services? And we are only talking about primary care settings, okay? The PHC, it could be a dispensary, it could be your rural health center. So maybe we can start with one. So the first question, is opportunistic screening being done at the center? So at the center which you are thinking about, you click one, you click yes or no, okay? Is opportunistic screening being done at the health center? That means, is NCD screening being done for all patients attending the health center, adult patients, irrespective of the reason for which they have come to the health center? Okay, so we'll give some time. All of you think about one particular health center and do it. It may be your own center or any other facility that you're familiar. Should we move on to the next question? Can we see the results now or later on, Dr. Ashisman?
And as you wish, you want to see the results right away, we can show it.
Okay, we can see it right away. I think that will also save time rather than coming back. Yes. I'm also conscious of the time because...
No, it's okay, ma'am. It's okay. Yeah. Okay. So this is the second question.
Okay, yes. So the second question is, are treatment guidelines available? Are treatment guidelines available in that center that you're thinking of? Yes or no? I hope all of you are able to do it. If anyone is not able to do, can you write in the chat box? Done? Okay, good. Can we go to the next? Is WHO CVD risk being assessed in that center? Is WHO CVD risk being assessed? Yes or no? Is it done? Okay, good. So we move to the next. So has the staff been trained in NCD diagnosis and treatment? Has the staff been trained in NCD diagnosis and treatment? Yes or no? Okay, I just want to tell you that this is actually a rapid assessment tool. It doesn't give you the details. Now, when we talk about staff, it could be, you could ask, are you talking about a nurse or you're talking about a health worker or a doctor? But this is a rapid tool, which is just going to give you an overall thing. But if you want to do a proper evaluation, you'll have to go more into details. Okay. So yeah, if any cadre of staff has been trained in NCD diagnosis and treatment, you can take yes. If not, then no. Somebody says about opportunistic screening. Okay, opportunistic screening means when any patient comes to your PHC or your health center who is above 30 years of age, irrespective of the condition or irrespective of the reason for visiting that health center, he or she should have the blood pressure checked, at least height and weight, and the blood glucose. So if that is done, then we can say opportunistic screening is being done. So we intentionally do not want to know which center you're thinking about, but this will give you an idea as to in the 140 centers that all of you are thinking about, how ready is it? Okay, what is the readiness? Now, next question. Is a BP apparatus available? I'm sure it must be yes for all. Okay, all of you please respond. If you have any problem in responding, just let the organizers know. How many people are attending, or 140 plus? Okay, so is this a good number?
It's 149 now.
149. Okay, okay. Okay, can we move to the next? Is the glucometer available? I'm sure that also must be yes and all. Hope so. Is the glucometer available? Okay, next. Is weighing machine height measuring tape available? Because we need to calculate the BMI. So unless the instrument is available, you'll not be able to do the measurement. You'll not be able to calculate the BMI. Okay, next. Are tests for urine, albumin, sugar, ketones being done? Here, let us take, even if it is done for urine, albumin, and sugar, you can take yes. Ketones, I don't know how many centers will do it, but I think we can allow for urine, albumin, and sugar. Yes. Okay. Next. Is blood sugar being tested? Okay. If the glucometer is there, then it will be tested, isn't it? Okay. Next. In some places, there's outsourcing of lab tests, according to the program guidelines also. So is outsourcing of lab tests done without the patient's expenditure? We are not talking about when the patient pays, they can get it from anywhere. But if there's an arrangement of the health center with any lab on an outsourcing basis. Okay, next. Then we come to the drugs. Are oral hypoglycemics available and distributed to the patients free of cost? So metformin is the only drug which is used. Okay, next. Now, when it comes to antihypertensives, we have just given amlodipine. It's the most commonly used, but in any kind of antihypertensives, if it is given, yes or no. Okay. Next. Do patients have a unique ID number? Now we can discuss this in the next session. Why is it important? So yes or no? Okay, done. Are 6 monthly control rates being monitored at the facility? That means here we are talking about hypertension as a tracer condition. So in your center, do you calculate the hypertension control rate 6 monthly? Okay, somebody's button is not working. Submit button, Dr. Subarna. Okay, next. Dr. Subarna, what you do is you calculate your own score in the end, and you can write down in the chat box. In the end, out of 20, we have 20 questions. How many? Okay, so next question. Are computerized records available? Yes or no? I can see some saying yes, that's very good. Okay, next question. Is there a system for recall and reminder? So is there any system for recall or reminding patients to come back? Okay, somebody's got the total score already. Next. Has any referral system been established with the secondary and tertiary center? Okay, okay, next question is there, Dr. Back referral system. Back referral means if you refer a patient to the secondary or tertiary, the patient should come back to you. I mean, there should be a system to inform you that, okay, this patient has been referred and this is the management that we're proposing, and it should be continued in the PHC. So that's also sometimes called down referral. Okay. Next, we're almost done. Does the center have IC materials for NCD risk factors? I'm sure that must be yes in all, almost all. Still some are no. Okay. Then the last question. Is dietary and lifestyle counseling being done at the center? Here, be a little bit honest. I know we say counseling is done every time, but is counseling really done to the patients, or is just telling patients to eat less salt and eat fruits and vegetables? So that is counseling. Is dietary and lifestyle counseling being done at the center? Yes or no? So we are through. Now we can see the results. First of all, now can you explain the results, Dr. Archisman?
Yes, madam. So I'm also reading aloud. What we could see is of 20 points, the average is about 14. So 13.7, 14. And then the range, like some of the centers are really scoring low. So starting from 6, and some of the centers are really good, like 20 on 20. Now,
okay, if I may just, I'll just complete my comments here. See, all of you can see that out of 20 points, none of the centers are actually fulfilling everything. Its maximum is about, maximum is about how much? Oh, there are with say 20?
Four centers.
Four centers, that's very good. But I don't want to ask which one, but those who have these centers, I mean, it's fortunate that you're working there. But maximum are not ready, means we don't have enough services. We are not ready, actually. What we say NCD readiness. We don't have enough facilities for NCD management. Okay, please carry on.
Yeah, I see a very good normal distribution curve shaping up here.
Yes.
So somewhere around 14.
Then let us see which is the maximum score. Yeah, if we look at the others, where is it where do we have all 20 out of 20? I mean the maximum, where everything is yes.
Okay, so that we need to download the.
Okay, yeah, just carry on with this. Let us go through this.
Here you can see, ma'am, this is question number 1. So these are the percentages here.
Okay, that's good. Guidelines are available in 81%. Very good.
No, 74.3%. Guidelines are
74. Okay, yes, 74.3. Okay. Okay. Rivu is asking who got 20. You want to know? We'd like to know if you don't have any hesitation in. Okay. So CVD risk assessment is done in only 1/3. Okay. Then staff training is yes. Generally it is yes. Okay. Then here we have PP apparatus is definitely 100%. That's good. Glucometer also, it should be 100%, but it's still there. Okay, not there in some. Weighing machines, and I expected 100%, but no, it's still 3 I don't have. Okay, then urine tests, 62%. Blood sugar being tested in 96, wherever glucometer is there, obviously. And outsourcing of labs. Okay, it is still there in 41%. Okay, that's good to know. Okay. Dr. Ravindran Center is 18 out of 20. So metformin is available in almost all the centers, which is good. And now I'm not going to ask how much is availability and how often do you patients receive medicines stock. 1 month, 2 months, 2 weeks. Okay, then highly hypertensive drugs, okay, 95%. And unique ID number. Oh, that's good. 61% have unique ID numbers. That's good. So is it really only for NCDs or is it total one? Now we won't know because it is a thing. Now, one more thing also here, I think many of you are from the same institution, maybe thinking about the same center. So also that is also that we cannot distinguish that. But in any case, it is good that, yeah. Next. Control rates, 36% actually calculate the control rate, which is good. Computerized records are available, and again 1/3. So those are the centers maybe who are doing control rate because it's rather difficult. And system for recall and reminder, okay, 20%, good. And referral system to the secondary tertiary, yes, it is there almost on all. But back referral system is not there. See, now you can actually see yourself where are the areas where we are lacking. Okay, I think if you make an analysis yourself, you'll understand that in your center, where are the areas which are lacking and what do we need to do to improve it. So we have another part of the activity, which is a qualitative part. Maybe Dr. Rivu Basu can take you through that.
Yes, thank you, madam. So welcome all. So I shall be sharing with you a link. Just click the link and wait. There shall be questions coming to your screen. Just wait for some time. There shall be questions coming to your screen. So I'm waiting. Please type in the words. It's an open-ended answer. So take your time. Okay, you will get around 3 to 4 minutes time. Just take your time and press your, give your answers.
Here you'll have to answer in reference to the center that you're thinking of. Okay, what were the things that were there or what worked in the health center that you're thinking of, not in general. Yeah.
Okay, is my screen visible?
Yes, it is.
So this was your first question. Okay. So what works for NCD management in primary setting, primary care setting? And if you can see the answers, the bold answers are screening, counseling, follow-up, drugs. There are a lot of answers. But if you look at the bold answers, they are the prominent trend. And we all agree to you. Right, madam? So
yes, this is good. Okay.
This is good. So counseling, screening, and follow-up drugs. Right. So what does not work? Let us come to that. So poor records, lack of awareness, lack of knowledge, and no follow-up. And no was missing here, no follow-up. So there is no follow-up, lack of records, lack of awareness, and lack of knowledge among the patient. That may be the cause of poor NCD services. Okay, that was also very good answer from all of you. Thank you. Next, we come to the third question. So what can be done to improve NCD services? So bold and beautiful training. Training is very bold and beautiful. Okay, so that's what we are trying to do here, training. Monitoring, capacity building, follow-up, and awareness. So your answers are absolutely on the target, right? So thank you for the exercise.
Okay, thank you. I mean, we have identified the problems now, but the next question would be how do we, what are the solutions? You know, it's not enough to, we all know these are the problems. So we will be having 2 more sessions, not today, we'll be organizing another 2 more sessions. And the first one could be how to organize the health services in a very systematic way. As you've seen that a lot of problems were on follow-up and irregular supply of drugs and all that. So like, how do we actually go about it? And second is the monitoring of patients. So subsequently, I think we will follow this in the same way. We will have 2 more sessions where we will discuss about these things more in details. Okay.
Yes, yes.
So yeah. So now another part of if we have some time, we wanted to just take you through the risk calculator. Do we have time to do that?
Yes, madam.
To do the CVD risk assessment?
Yes, we do it.
Okay. So I hope all of you have downloaded the app. Now I'll hand over to my residents to conduct this. So all of you kindly open the app and go to the CVD risk calculator. Okay, Dr. Anam Alwani is my resident. She will be conducting this part of the session.
Good evening, everyone. I'm a resident in community medicine in AIIMS, and we'll be going through WHO CVD risk assessments. So if everyone's opened the app, and as Buddy ma'am said, we can move on, as in if you've opened the lab-based and non-lab-based CVD risk score calculators. So the first question. So this is the first question on the screen. A 55-year-old female, non-diabetic and non-hypertensive, with no history of tobacco use, came to the OPD for routine health checkup. Her blood pressure recorded was 180 by 96 millimeters of mercury. She weighed 64.2 kilograms and was 1.5 meters tall. Her BMI is 28.5 kilograms per meter square. Calculate the risk of CVD in this female and manage accordingly. There are 2
Show it in
CVD.
screen show, Anam. Can you just make it in slideshow?
Okay.
Yes. That's it.
So there are 2 CVD risk calculators, as ma'am said. One is lab-based and the other is non-lab-based. So your first decision would be to decide which one to use. The differences for lab-based, you'd need whether the patient is a diabetic and her cholesterol values. So accordingly, if you all can, on the app, go ahead and try and calculate the CVD risk and post it in the chat, and we'll move ahead after that.
Anam, can you see the chat box? They are giving the answers.
Yes, yes. I think 3 people have replied. The 10-year risk is 9%.
Yes.
So,
so you
that
can
is
the answer. Yes.
Yes, that is correct. Sorry, my screen's hanging. So that is correct. The total cholesterol is not available, so we have to calculate the non-lab-based score. And as you all said, it's 9%. Moving on to the second question. Wait, does anyone have any doubts in this one, or has everyone understood it?
Country India, you have to take India as the country. I don't know how, Dr. Debanjana, you got 19 or 17, but it is 9. You have to use the non-lab based.
It says no history of tobacco use in this. So moving on to the next question.
So how are you going to, yes, alcohol, tobacco is so dangerous. It increased the risk from 9 to 17. Okay, Udita, can you? Okay,
Yes, yes,
Dr. Udita is another resident of ours. She is Anam's batchmate. Okay, carry on.
Okay, now coming to scenario 2, a 48-year-old male student studied up to 12th standard and is an agricultural laborer by occupation. He smokes BD since the age of 25 years and is recently diagnosed with diabetes. He's 169 centimeters tall, weighs 86.8 kgs. The BMI is 30.4 kg per meter square. On examination, his blood pressure is 160 by 94 mmHg and his total cholesterol is 251 mg per dl. We've given the cholesterol in millimoles per liter as well, that is 6.49. Calculate the lab-based and non-lab-based CVD risk score for this person and provide management according to the WHO PEN guidelines.
Here I want to tell you about CVD, about the cholesterol. Remember that when you use these charts or the app, you'll have to enter it in millimoles. So there's a conversion factor which is provided in the app.
So these are there are some answers.
Okay.
Yes, I am seeing the
You can
answers.
show the answers. They are all correct.
You can go to the
Yes.
answers now. So yes, the lab-based risk score is 22% and non-lab-based is 12%. So now coming on to the management. So for the lab-based risk chart, these are used for the treatment decisions. And over here, we can see that it is 22% the risk. What the management will include will definitely have counseling on the diet, the physical activity, smoking cessation, and avoiding the harmful use of alcohol. We've seen that the cholesterol levels were high, so giving statins here should be considered. Now, if the blood pressure is persistently high, then we would obviously start the patient on an antihypertensive, and the follow-up will be every 3 months. You can see even in the WHO PEN that according to the CVD risk, they have given guidelines for the follow-up. So in this case, the follow-up will be every 3 months. We can go to the next question now.
Should we go through or we can stop here? In fact, I think if there are any questions that somebody wants to ask. Okay.
We can continue if you have, like, this is the last scenario. Maybe
there are two more. So maybe quickly we can just go through this and okay.
Yes,
yeah. Okay, Anam, please go ahead. Okay, a 59-year-old patient came to the PHC with complaints of polyuria and polydipsia for 1 to 2 months. She had no history of tobacco use or alcohol and no chronic conditions. She's 164 centimeters tall and BMI is 27. On examination, her blood pressure was 145 and random blood glucose was 340. Remember, here we need to take the systolic blood pressure only, not the diastolic. Okay, so those of you who have calculated, can you? Seven. Okay. Okay, I think now we all got it. Some of you could not figure out how to use the app. I think you have just downloaded it, but I think you just take some time and once you familiarize yourself, it's going to be very easy. So next, let's go to the next question. Scenario 4. Okay, so this is a bit tricky one. Anam, can you read it out? Oh, yeah.
A 60-year-old male patient comes to the NCD clinic for the management of hypertension. He used to smoke cigarettes, but stopped after the episode of a stroke 5 years back. His BMI is 27.8 kilograms per meter square, while his blood pressure is 126 by 72 millimeters of mercury. On lab investigations, his HbA1c is 5.4, total cholesterol is 147. To which category does he belong according to WHO CVD risk prediction? So in this, actually, cholesterol is given in milligram per deciliter. So to convert it, we would multiply it by 0.02586. But in this question, there's a catch. So let's see if any of y'all can identify that.
Okay, I think to save time, I would advise that you do not try to do this in cholesterol conversion. The answer is, since the patient already, yeah, can you go ahead?
So since the patient has already experienced a cardiovascular event, which we said in the previous question, he has had a stroke before, he's anyway considered high risk. So no matter what the calculation comes to, he should be managed as someone with more than 20% CVD risk.
Okay, thank you. So I think now the confusion, maybe a little bit, the point which is not very clear here is because we did not explain about the CVD risk assessment properly. I didn't have time, but I have a recorded lecture which I have will be shared to you in the end of this webinar. Please listen to that lecture and go through it properly, and you can actually do, then you'll understand the details about the CVD risk assessment. We didn't want to take too much of your time because there's another session after this, but it's great. I hope you all learned and you will be able to, and if you have any questions or any queries, you're most welcome to ask me anytime. My email ID is there. I'll just again put it in the chat box. So anytime you can call me. I mean, you can contact me through email.
Thank you, Madam, and thank you, Dr. Udita, Dr. Annam, for the facilitation. Rivu,
Yes.
yeah, since Shaili is not here, could you please do the formalities and move on to the next session?
Okay. So thank you, Dr. Ajishman, for and thank you, Barry Madam, and your excellent team for the nice exercises. So it was, I think, most helpful for the participants. And be rest assured that we will be having a larger version or more detailed version of this exercise soon. In the post, we will be announcing soon via grid. So stay on our channel and keep listening to us, because we will get the news of the course as soon as it flashes. Okay. So this was only just a very small glimpse of the course. So the course will be very much detailed. So you can do an actual manual survey of your health system and all those things. And these things will be done after 2 months, perhaps. Okay. So kindly stay with us. And thank you again, Madam, and your team for the nice exercises. So now we move on to the second part. So in the open-ended word garden, you all saw that what was the problem? Counseling was the problem, right? And yes, we have been seeing from various sources, we have been triangulating from various sources that counseling is the problem, or proper risk factor management. You need to have very evidence-based counseling, and thus we had this project in running, INTRISK Cohort 1, which was funded by World Density Federation. So this project was funded by World Density Federation as a part of a competitive grant, and we have with us the representative of World Density Federation, Ria Nangiar. I have the privilege of introducing our other investigators of this project, who are Dr. Achishman Mohapatra from Grid Council, Dr. Shaili Vyas, and we also had Dr. Neha Sharma, who has been working intimately with us throughout the entire project. So as you know that today is the Doctor's Day, right? And we thought that we can have this program on Doctor's Day itself, because this is one of the most important topics in India now, that we are not able to counsel the patients properly for the management of the NCD risk factors. So that is why we designed this project. You have all participated in the project as interviewers, interviewees, or many of you have also completed the first cohort. So it was we are highly obliged to have you with us. So I think, Achishman, we can move on to the presentation now.
Yes, please.
Now I hand over the mic to Dr. Rohit of AIMS Rishikesh, who are an SRE in AIMS Rishikesh, to continue with the presentation. Thank you.
Thank you, sir. Good evening, everyone. I am Dr. Rohit Katre, working as senior resident at AIMS Rishikesh, and was a part of Project Indrani as a co-PI, and was also one of the participants in the first cohort. Ma'am, can I have next slide? So non-communicable diseases, which includes cardiovascular diseases, cancer, diabetes, chronic respiratory diseases, mental and neurological disorders, account for 68% of global mortality and are the leading cause of death and disability worldwide. It can be seen that it can be seen that from the that 1 out of 10 adults in the world are suffering from diabetes, while while 1 out of the 5 adults in the world have hypertension. So this graph shows that presently there is in India there is a dual burden of both communicable as well as non-communicable diseases. And this graph also shows that there is a rate of increase in the NCD burden overall since last decade. Now coming to the map, this map shows that the proportion of healthy years lost, which is measured as a daily due to NCDs, were globally estimated to be 64%, while for the India, it is estimated that the proportion of healthy years lost due to NCD will lie between the 50 to 60%, and is only expected to rise. So keeping this in view, the project INDRANI, which stands for Integrated Disease Risk Management Approach to NCDs in India, was taken up to develop a module for integrated management of risk factor for NCDs among postgraduate students of community medicine. Now I will like to hand over the session to Dr. Rivu sir, who will be discussing the objective and methodology of Project INDRANI. Thank you.
Well, thank you, Rohit, for introducing. So, Neha, please. Okay. So the objectives we had is to develop a module on integrated risk management of non-communicable diseases for junior residents of community medicine. And our objective 2 was to determine the efficacy or effectiveness of the module in managing risks of non-communicable diseases among individuals. So these were our 2 objectives. So let's see the methodology. So this was the methodology we adopted. It was based on the ADDIE model. Okay, the ADDIE model, what is it? It is a very common model used for development of a module, where the initial phase is the analysis of the need assessment. The next part is the design and development. The third part is the implementation and evaluation. As Dr. Archishman was talking about systems thinking or design thinking, this is the part of our design thinking itself. So first 3 months, we did a background search with a review of literature. We searched for the existing evidence. Neha, can you go to the next slide, please? Okay. So we had the experts' opinions. We took the experts' opinions, and for the experts' opinions, we selected experts from national and international arena too. We did an in-depth interview of the experts. 12 experts who were interviewed. We also did an intensive interview of junior residents, 66 junior residents of community medicine by in-depth interviews. It was impossible for us to do this by ourselves. So we trained a cohort of 11 trainers for this who continued the work for us. So after the initial need assessment, we validated that with the Google form sent to the interviewees, and then we moved on to the next stage. What is that? The design and the development we took for 2 months. So then we searched for the literature, and then we came up with some resources which we found all over the world according to the need assessment part. Thus, the model was designed by brainstorming. After the model was designed, we did Delphi technique or a modified Delphi technique with experts to validate the module. And the experts went to the module. They said this can be included, this cannot be included. They said about the agreement regarding the contents also. Thus, we calculate the SCVI indexes and ICVI indexes of this. And then after the module was developed, we planned for the innovative teaching learning methods which we can to increase the participation or increase the teaching learning part in the considering the module. And we used a learning management system like Moodle for final course integration. Okay. So after that, we floated the module. We floated a Google form through all the channels we had. And there were many participants who initially accepted, but then we had an introductory session where we were very strict regarding the fact that they had to attend all the sessions, submit all the assignments, and do the role plays and simulations as expected. So for that, maybe many of them dropped out because that was not matching their time schedules. So we had 20 people who completed our initial certification, and congratulations to all of them. So next was the implementation and evaluation part. There were 5 interactive sessions where we had case studies, quizzes, role plays, reflection writings, etc. And then we used a pre-test, post-test to understand the K and the KH domains of the effectiveness of the program. And there was a very innovative exercise where they recorded a role play of 4 case-based scenarios, and we had a peer review assessment on them in the last session. So this was initially started by 56 junior residents, but only 20 were able to complete that. So after the methodology, I'm handing over the so the results of the expert interviews. So the expert interviews, the experts were unanimous, rather the experts were mostly having consensus on some factors. Like there was a huge need for risk factor management because they all knew that NCDs was on the rise in India, and if the risk factors were not managed properly, the NCDs will keep on rising. Only treatment will not do any help. So the risk factor management was required, and they also understood the fact that like lack of proper counseling or lack of evidence-based protocol which a physician should deliver to a doctor was a chief reason for non-adherence to lifestyle factors. So they were of the opinion that structured training of the physicians should be done on the management of risk factors. Actually, when we interviewed our international experts, they said that many of the countries like UK and USA and even Australia already had this kind of a training program, but we were somehow lacking this kind of a structured training program. So with their advices, we formulated this blended mode of learning with innovative techniques as this part of this INTRISK cohort fund. So with this, I am now handing over the mic to Pallavi. Please continue with the presentation. Please, Pallavi.
Thank you, sir. Good evening, everyone. So I'm Dr. Pallavi Singh, presently working as Senior Resident in the Department of Community and Family Medicine, AIIMS Rishikesh. And I have been part of project in the Rani as a co-PI and also the member of the first cohort. So I will be presenting to you the results or the responses of our respondents that we got from participant interviews. This will be like in brief about what all we did. So as sir has mentioned, we did a total of 6 interviews. So I will be summarizing the results of this. So the results can be described under 4 main domains. Ma'am, can you just move the slide? Thank you. So the first domain was NCD risk factors and burden. So most of our respondents, the responses that we got were that, I'll just first cover the domains. The first domain was NCD risk factor and burden. The second was advice on lifestyle modification. The third was adherence to advice. And the fourth one was the training regarding risk factor management of NCDs. So under the first domain, that is non-communicable diseases, risk factors and burden, our respondents said that the most common risk factors that were found were dietary factors, that is unhealthy dietary habits, sedentary lifestyle, lack of physical activity, motivation, lack of motivation to do anything regularly. Stress was a major factor. Most of the patients that the respondents were facing had high level of stress, and also drug abuse was one of the cause. Under the domain of advice on lifestyle modification, so our interviewees said that though they tried their best to counsel the patient to the best of their knowledge, there were time constraints because OPDs were heavy most of the time, and there was communication gap. Sometimes the patient did not want to listen, or didn't have the time, or didn't want to, or they were thinking that the medicines will be enough for them to get treated. So they did not pay too much heed to the counseling. And one important thing that can be pointed out was that there was non-availability of specific guidelines regarding the counseling. So most of our respondents felt that there should be a proper uniform guideline all over the country, so that all the patients get a fair counseling and a equitable kind of counseling. The next was adherence to advice. So most of the respondents said that the socioeconomic status of the patients, the education level of the patient, was a major factor to for less adherence to advice. Most of them did not adhere to these advices because of these factors. Also, very few of our respondents had the proper follow-up mechanism. They did not have a designed follow-up mechanism for following whether there was adherence or not. The last domain being training regarding risk factor management of NCDs. So with consensus, most of the, ma'am, can you just move this slide? Most of our respondents said that they had no training received and there was a need for the uniform guideline. So these were the main 4 domains which our participants talked to us about. So now I will like to hand over the proceeding to Dr. Neha Sharma, ma'am, who will be talking to you about the course design. Thank you so much.
Thank you, Pallavi. Yeah, hello and good evening all. Am I audible?
Yes, Neha.
Yeah. Hi. So I'm Dr. Neha. I'm currently working as assistant professor in community medicine department at Himalayan Institute of Medical Sciences, Dehradun. So as my previous speakers have told about the the course designing, development, implementation, and evaluation, I'll just walk you through how we did it and what were the results of the our course of the project Indrani, basically. So using the modified Delphi technique and through online meetings, the study group team basically went through the rigorous brainstorming sessions to prepare the course. And finally it was decided that we'll have interactive sessions. You can see the topics regarding the, like, day one we will tell them about the introduction to modules. Then in the subsequent sessions we'll make the residents familiar about the integrated management for the NCD risk factors, the consultation models, risk scoring methods, how we can check the cessation for the tobacco and alcohol and advise them accordingly, how we can perceive the stress and you can manage in the patient, and the suggestions regarding the dietary modifications and the exercise. And the last session was planned for the objective structured video examination. So based on these sessions, the this course, the plan of everything was given to the experts and to the interviewees. And these were the results of the interviewees, which they thought of the course structure. As you can see, this radar chart basically shows only two sections: strongly agree and strongly disagree. When we gave them the form to assess the course, it was on the Likert scale, but due to avoiding the clustering, we are just showing the two components: strongly agree and strongly disagree. So as you can see, on for the introduction to the integrated management and risk factors in the management of NCDs, 50.8% of the interviewees strongly agreed to it, followed by assessment of risk of common NCDs with standard tool, which was 30.5% of the interviews agreed to it. Then 42.4% of the interviews said that assessing the improper diet and advice accordingly was given in the course structure. Overall, they thought that the course has the proper learning management techniques. Based on the experts review, basically the item level content validity index for all the parameters was more than 0.8, and it was showing good agreement. The experts also suggested some modification in the design and the development of the course, which was incorporated in it. So finally, the session was executed in the following manner. Like, firstly, when the session was started, your junior resident and they were told about the questionnaire. They were given the pre-reading materials, books, and the learning resources were also shared to them. Then it was some kind of videos were shown to them, how they can improve their counseling skills, how they can build rapport with the patient, and of course assess the NCD risk factors. After that, a case study was given to the participants, and they were distributed in the breakout rooms, which was mentored by the one of the organizers. They discussed among themselves on that case study, basically to have a one-to-one interaction with their peers also and with the mentors also. And after that breakout room, they were invited again to the main room, where they performed the role play, one person acting as a doctor and one as a patient. And on that, the peer review discussion and with the mentors were done. After the end of the session, the junior residents, the participants, were given the assignment, which was again based on the case studies only. And they were also asked to fill up the reflections, which were in the form of what happened, so what, and what next. They were also asked to give us the feedback, which was again on the Likert scale. All of the sessions were done in the following manner. In the last session, on the last day, the objective structured video examination was done. In this, basically few days after the second last session, they were given some case studies. They were divided into teams, and again there was one mentor for them. They discussed among themselves, they prepared the script, they recorded the video, and on the last session, they basically the video was shown to their peers also, and it was peer reviewed. Based on the completion of the pre and post test and 100% attendance, only 20 participants were given the completion certificate. The results of the sessions were, when we were asked them the feedback for the introductory session. So as you can see that for the registration process and for the ice breaking, 32 to 38% of the participants were very satisfied. For onboarding, pre-reading, pre-test material, 38 to 42% of the participants said that they were satisfied with the material. However, when we were asked to tell them about the Moodle orientation, they were not very happy with the interface, and later on it was demonstrated to them. Overall impression was around 45.2%, like they were very satisfied with the introductory session. For all the subsequent sessions, the mean feedback scores can be seen in the graph, as you can see, and same questions were asked in the Likert form, ranging from 0 to 5, where the participants were asked about the learning objectives meeting their expectations, were the resources aligned with the objectives, how did they like about the mode of facilitating, the feedback assessment, the interface, and the faculties helping them in addressing the learning needs. So as you can see, for the mean scores, all of the scores are more than 4.2 in all the sessions. So overall result was, when we compared the pre-test and the post-test result, there was a rise in 8-point score, and it was statistically significant. The Cronbach's alpha also was 0.8, which showed the good agreement. For Cronbach alpha of all the feedback session, it ranged between 0.8 to 0.98. Hence, this course actually made the structured module which focused on the counseling, behavior change, communication, lifestyle management, and it also incorporated the blending learning methodology, which is Moodle as an interface, which is a skill-based training. However, we cannot deny the fact that we had some limitations, and since it was a small group and the participants usually volunteered themselves to be part of it, and some of the participants who actually registered or enrolled for this, but they had to leave out due to because of they were third-year residents and they could not match with the timings and with the process of it. And also we saw that developing skill training online is a very difficult thing, which we will improve upon, because it's a learning phase for ourselves also, and for Project Indrani. After that also, we'll continue to evolve this course and continue further. So we had some beautiful testimonials also by the study participant, which and their kind words really encouraged us. So Dr. Annapurni from Grant Medical College, Mumbai, Dr. Dipanshi Saxena from Cephai, Dr. Reddy, Dr. Emmanuel Joshua from BHU, Dr. Lavanya from Puducherry, and Dr. Haripriya. We would like to play Haripriya's video.
Hello everyone, I am Dr. Haripriya, a third-year resident of Community Medicine from Chalmeda Anandrao Institute of Medical Sciences, Karimnagar. I am extremely delighted to be a part of this Integrated Risk Management of Non-Communicable Diseases Cohort 1. The course is designed in an incisive way with a patient-centric approach that is used for practical application in day-to-day life. The course covers various modules like trans-theoretical model of behavioral change, 5A 5R approach, stress management, physical activity, all those things that helps in behavioral change and lifestyle modification of an individual, which finally helps in preventing the non-communicable diseases. We also had an amazing team of mentors, Dr. Achisman sir, Dr. Ribu sir, Dr. Neha ma'am and Dr. Shaili ma'am, who were extremely friendly and cooperative and encouraged us for performing all the team activities in a very nice manner. I will be extremely thankful to them for all the support and encouragement they have given us, and needless to say, I have got a good bunch of friends through this. Thank you so much.
Thank you to all the participants, and I would like to ask Dr. Atishman sir to please carry forward.
Yes, thank you. Thank you, Neha, and everyone for this wonderful presentation. And all our audience, please stay back. We'll have a group photograph at some point of time now. Now, this has been a sort of learning as well as overwhelming experience. We applied some of the concepts of design thinking to it, and we empathize. So when it comes to NCDs, actually it becomes a no man's land. We don't really know what is happening at the primary level. So we try to define the problem, and then we try to ideate like what could be a potential solution, and then we prototyped a program and experimented. Like we tested it with colleagues, and now we are in the iteration phase. One of the biggest learning that we have is this wonderful return on investment. Like when we invest in young people, like young residents, and the return is massive. This program gave an opportunity to play the role of an investigator for the residents, and they went around, tried to do a pan-India study with a very frugal budget. And then some of them like went on to win prizes. So in the International Society for Lifestyle Medicine conference, they won the first prize, Emmanuel and Johnson. And others are also very excited. So this is quite encouraging. We are now planning to revisit the course, enrich it. Now with Bari Madam has highlighted many new concepts today. We will enrich this course much further to make it more tangible and applicable at the primary level. And we hope that we'll receive more participation going forward. This has been a massive mobilization exercise. I must acknowledge the support we received from all. Neha, do we have the slides?
Yes.
Yeah, so we had experts, like very senior people who we could talk to as we ideated a solution. Next one, please. And then we spoke to residents across India. So it was sort of snowballing, a qualitative exercise. So primary data collection, trying to make it as attuned to their requirements. Next one. And these are the cohort 1, those who received the certificate of completion. So Drs. Alanki, Ambika, Annapurani, Dipanshi, Prashant, Haripriya, Johnson, Kosturi, Lavanya, Ramaswastika, Pranav, Prerna, Riddhi, Shalini, Seethal, and Tarun. So now some of them actually participated in the data collection. So some kind of internal validity, sort of like we had internal auditors as well as external auditors. Yeah, next one, please. Now these are the co-investigators: Ankit, Archita, Arnab, Emmanuel, Johnson, Lavanya, Manisha, Neha, Pallavi, Rohit, Venkatesh. So these are people from across India, and nobody interviewed colleagues within the state. So someone in the east spoke to someone on the west, someone in the north spoke to someone in the south. So these were like zigzag. Yes, next one. And this is the program management team that helped in coordinating. So Doctors Ritvika, Priyanka, Bharati, Divita, Kavita, Chandra, Shikha. We had 2 fantastic interns, Prachi and Ashvi. So this was a massive coordination exercise that happened, and this is the internal team that helped in doing that. And of course, the PI, Dr. Rivu, and co-PI, Shaili, and Neha. These have been the anchors of this entire course. So yeah, Neha, is that the last slide for?
Yes.
Yes. So if you could stop presenting.
Yeah.
Now, Neha, please stop your screen presentation. Yeah. So now Grid wants to bring more and more hands-on designed courses. We want youngsters to get involved during the residency, take a flavor of pan-India studies, and if possible, go international. Simultaneously, many such innovative training courses are offered on different platforms. We are working on courses on one hand. We are working very closely with development partners, organizations in the research and MLE, knowledge management. We are also working very closely with the industry in the biotech, in the startup front. So some training opportunities come up, we'll try to share with them. But suppose you have a skill or you have undertaken a particular training and you want to share it, come forward. We are ready to have this high risk, high gain kind of experiments. You want to experiment, you want to fail fast, do it on this platform. Come forward. Just ensure that you have good quality. Don't misguide people. So ensure that you put in the best effort, get the best faculty, come and experiment. There are takers. Just develop those entrepreneurship aptitudes. Now, that brings us to an end of this webinar. We had to close by 7:45. We are 3-4 minutes before that.
Just one thing, is Dr. Ria here? Actually, Dr. Ria is having some problems connecting, so maybe we can just mention her name only. That Dr. Ria was the representative from World Density Federation. Okay, so she was there for the like previous the last day of the interactive sessions, but she is not been able to present today. So thanks to World Density Federation, led by Dr. J.S. Thakur sir, we want to extend our heartfelt gratitude to you, because it is because of you we manage the entire thing. So over to you again. Okay.
Yes, of course, Dr. Thakur, World NCD Federation, Dr. Ria, and today Dr. Barry ma'am. She has been working very patiently with us. Like, it's been many days of background work that has fructified in this presentation today. Ma'am, thank you so much for this hands-on training. In fact, it's very difficult to differentiate like what exactly is a general practitioner and what is a primary care specialist working. So you brought in those public health expertise to the primary level. We have some very senior faculty who joined us today. So this is a moment to thank those senior people who took out time to participate in this discourse. I would request everyone to please switch on your videos so that we could take a group photograph. We will try to edit this and then make it a shorter video, a more crisper one, and release on the YouTube channel. Yes, so please everyone, please switch on your videos, please. We'll take multiple, 6 photographs actually.
It's been really interesting and encouraging to see the response from the students and from the participants from all over. So I hope that all of you have, gained some extra knowledge today. And anytime that you want to know more about NCDs and primary care, please, you are free to contact me anytime. And I hope to see you again in the next session. Thank you.
Yeah, thank you, madam. We will be announcing cohort 2. So we are doing some background improvement in the course. We'll be announcing cohort 2. But as Barry madam also told today, we shall be also having webinars on how to organize NCD care services at primary level and also how to do cohort monitoring. So those are important topics. You'll find it hands-on. The moment you come out of medical schools, you're into programs, suppose you're into NCD programs, this will give you real life skills. Yes, so we'll be sharing some post-webinar reading material, some resources. Okay, so thank you so much. Let's join in for the next webinar when due. Thank you for joining in.